I'm here to introduce Dr. Keiran Tuck. He will be presenting on advanced stages, as you can see up here. So to give you a little bit of information about Dr. Tuck, he grew up in the US and studied medicine at the University of Sydney in Australia. That's a place I would like to be right now. He completed his neurology residency and fellowship in movement disorders at the Oregon Health and Science University in Portland, Oregon. Since then, his research on palliative care in Parkinson's disease has been published, and he was named the co-director of the Legacy Portland's Parkinson's program. He recently moved to Victoria, BC, yay, to start a Parkinson's and movement disorders clinic at the Royal Jubilee Hospital. So please welcome me in welcoming Dr. Tuck. Really appreciate it.
Thank you. Thank you, Stacy. Thank you guys for having me here. I also want to congratulate you all for showing up for this session. I think this is a really hard topic for a lot of people to sit and think about and to contemplate, but I think it's a really important topic in this disease and in life in general. It was interesting. There was an article in the New York Times about a couple weeks ago about how your brain kind of prevents you from thinking about death as a kind of survival mechanism, essentially. That we often think about death as happening to other people and not to ourselves. And while that's probably really helpful in a lot of situations to not worry about the end of your life, it also causes a lot of problems if you don't plan ahead. And so I'm gonna try to talk through kind of Parkinson's and the end of life, and hopefully we'll have a little bit of hope at the end. So I don't have any disclosures. No one pays me other than the province of BC. So we're going to talk a little bit about the Parkinson's disease as kind of a multifaceted disease with a lot of different heads, just like the Hydra from ancient Greece. We're going to then kind of focus in on cognitive changes and dementia, talk a little bit about that. We're going to talk about mortality, so kind of what the end of life kind of looks like in Parkinson's disease. And then we're going to talk a little bit about palliative care, and part of palliative care, which is advanced care directives. So in 1812, James Parkinson wrote this essay on the shaking palsy. And this was the first description of Parkinson's disease. So Parkinson's disease had probably been around for many years, but no one had really described it. And this was the original description of that condition, and hence why we call it Parkinson's disease. And in this essay, he talks about what he observes in people who have this condition. And so he described shaking. So he called it the shaking palsy. He obviously didn't name it after himself. He wasn't that conceited. But he described shaking, which we now call tremor. He also described it as a palsy. And we would just say palsy, we've kind of refined that term a little more to be the bradykinesia, or the slowness of movements with Parkinson's disease. And then he does describe troubles with gait and balance, which we now term postural instability. Now, he never described rigidity, this kind of stiffness that your doctor probably feels your arms and your legs and feels this kind of, cogwheeling or stiffness in your muscles. He never described that in his paper because he only examined 2 of the 6 patients that he described with this condition. The other 4 patients he just saw from a distance or went in the room and said, yeah, you look like you have Parkinson's, and talked to them, but never actually examined them. So a very observant person, but it wasn't a full picture at the time. But now, 200 years later, we have a fuller picture of Parkinson's disease. And when we think of Parkinson's, this is mainly what people think about, is all these movement problems, motor problems of Parkinson's disease, these 4 problems. But as you all know, there's a lot more that goes along with Parkinson's disease, right? So, and I kind of think of this as the Hydra. So in ancient Greece, there's this myth of Hercules going to kill the Hydra, and the Hydra has lots of different heads, and you cut off one head, and another two grow off of that stalk. And so Parkinson's sometimes feels a bit like this, where there's just so many things going on, right? And we can think of, constipation as pretty common, pain, depression, restless legs, impulse control disorders. There's a lot of medical issues that can go along with Parkinson's disease. And a lot of these have, there's medications you can take to treat these. There's physiotherapy. There's a lot of kind of, medical treatments for these. But there's more, right? I mean, we all know that Parkinson's also affects your life, right? It affects kind of everything about your life. And it can cause strain on your caregivers, your friends, your family. It can cause spiritual distress. What does it mean to be who you are? If you were someone who was an avid violin player and you're no longer able to play violin because of your Parkinson's, I mean, that affects your whole spiritual nature of yourself as well. Obviously, the movement problems cause a lot of issues of getting around. Transportation can be a huge problem. It can cause trouble with your relationships, not just the speech issues, but you kind of slow down a bit, and so it's harder to get involved. It's harder to communicate with your friends and family. And then we also think about, well, what does the future hold? It's really it's pretty common when people get a diagnosis of Parkinson's disease to become depressed, to have a reactive depression. And we see this in lots of different conditions. You get diagnosed with diabetes, the same thing happens, right? And it's that kind of fear of the future, fear of what's coming, right? Fear of what the future may hold for you. And so there's a lot more other than just medical issues that is important to think about when you have Parkinson's. So sometimes you feel a bit like this. So I just want to say before I go forward, if you guys have any questions, if you want to make a comment, please raise your hand, call out. I'm happy to make this interactive. Don't be shy. We can stop and take a side discussion. I'm really more than happy to do that. Okay. So let's talk a little bit about cognitive impairment. So this is one of the things that I think scares a lot of people, right? When they get the diagnosis of Parkinson's, this is a disease of the brain. I mean, it affects the rest of the body, but mainly is a disease of the brain. And so a lot of people have this fear of cognitive impairment, whether just they've read it online, you've had a friend who you've known, or someone in the community that you've met who's struggling with this, or it's just something you've kind of heard about, right? So let's just go over a few terms first, kind of to help you with some vocabulary when we talk about cognitive issues. And when we talk about cognition is essentially just how you think, your thinking and your memory. So the first term I think is important to know is pseudo-dementia. So there are people who, who feel like their memory is not as good as it used to be. They feel like their thinking is slowed. They feel like there's a problem. And maybe you do a test. There's a few different tests that your doctor can do in the clinic, just kind of brief tests to check how your memory is doing. And maybe you do poorly on those tests. But people with pseudo-dementia, it's not caused by an actual structural problem with the brain. It's really caused by a medical issue that is affecting how your brain's functioning. The most common ones are depression. So people with depression, you're slowed, your thinking's slowed, your memory's poor. It's really well documented that people with depression have pseudo-dementia. So it looks like they have dementia. Maybe it's not severe dementia. It's usually very mild. But they can look a lot like they have a cognitive issue. But it's just their depression. And if you treat the depression, the cognitive issues get better. Another common one is sleep problems. If you're not sleeping well, your memory is going to suffer. Your thinking is going to suffer. I mean, I think we've all experienced that, right? When you've had a terrible night's sleep, you just don't function well the next day. So there are plenty of people who that's a chronic ongoing problem of not sleeping well, and their memory doesn't work as well. But again, if you fix the sleep problems, the memory problems get better. So that's the first term to know about. The next term to know about is what we call mild cognitive impairment, or MCI. So essentially, there's a few parts to this. So again, the patient feels that they have a memory problem. So this is the subjective cognitive impairment. You have a lower than normal score on one of these, cognitive tests, one of these brief cognitive tests, but there's no obvious cause. And further to that, there's no impairment of your day-to-day life. So if you come to me and you say, I'm just not thinking well, I feel like foggy in the brain, and we do a test, and you're score a little bit low, but then I ask you, well, are you still working? You say, yes, I can still work. And I say, well, are you still doing your hobbies? You say, yeah, I go bowling, I read books, I'm just slower, it takes me time. And I say, well, are you able to dress yourself? Yes. Are you able to get to the store and back without getting lost? Yes. So you don't truly have dementia because you have no disturbance of your day-to-day life, but there is something going on. And so we call this mild cognitive impairment. The next step up the list is dementia, which the key to dementia is this impaired daily function, which essentially means a lot of these things we just mentioned, dressing, eating, doing the finances, doing your hobbies, things that you normally did throughout your life, you're having trouble with one or more of those things. And that class qualifies as dementia. So when we speak of dementia, a lot of people will always ask me, oh, I have Alzheimer's then? And they're not synonymous with each other. So dementia is kind of the broad term that means your brain is not functioning properly, or your cognition is not what it should be, or what it used to be. But there are lots of causes for that. And Alzheimer's disease is one cause of dementia. Lewy body dementia is another disease of the brain that causes dementia. If you have lots of strokes that causes dementia, we call that vascular dementia. And these are probably three of the most common diagnoses of dementia. They can be mixed as well. So you can have vascular disease and Alzheimer's. You can have Lewy bodies and vascular disease. You can have Parkinson's disease dementia and Alzheimer's. They can be mixed. They overlap a lot. And there are lots of other causes of dementia that are very rare. Yeah. So yeah, Lewy body dementia is a very specific type of dementia where people look a bit like they have Parkinson's. They have kind of the slowness, the stiffness of Parkinson's disease, but very soon around developing those movement symptoms, they develop dementia as well. So you can kind of think of it as a very aggressive form of Parkinson's disease. A lot of the pathology in the brain looks very similar, but it seems to affect the thinking part of the brain more than the motor part of the brain. And classically, people with Lewy body dementia have a lot of hallucinations early on, and they don't react well to levodopa. Levodopa makes them even worse. So it usually makes the hallucinations worse. Yeah. So we'll get to that in a little bit. I mean, the reality is all of these diseases, there's no way to diagnose them without taking your brain out of your head and looking at it under a microscope. So we kind of classify these as probable or possible. We'd say you have probable Lewy body dementia. But we don't know for sure unless you actually, we have an autopsy, right? And the reality is a lot of these dementing illnesses overlap in their clinical picture. So you're right, hallucinations are much more common in Lewy body dementia, but can happen in any of these diseases, right? So it's it's hard to give people 100% answers about what their exact diagnosis is. Just we don't have the tests to be able to do it at this point. Yeah. Yeah. Hmm. Hmm. Yeah. Yeah. Yeah, so I guess the way I would answer that is, we have these specific kind of names of things. The reality is life is not, you don't go from level to level, right? It's a spectrum. So I honestly don't know whether trouble with remote controls classifies as dementia or not. But right. But I think it's certainly an indication that you're here, but you might be moving in this direction, right? If that was something that someone could do previously and is now having trouble doing it, as long as it's not a physical issue, as long as it's not a vision issue, if it's truly a cognitive issue, then yeah, you're moving in that direction. And this is really a spectrum, right? Yeah. So as we talked about, right, the diagnosis is really difficult without brain tissue, right? And what we see on brain tissue, so this is a scan of or a slide of someone with Alzheimer's, and you see all this protein that's kind of built up throughout the brain, and this is called amyloid protein, right? Whereas in Parkinson's or Lewy body dementia, you get these little bodies in the brain called Lewy bodies, right, that fill up the cells. Often it really doesn't matter, right? I mean, to be very blunt, I know there are some of my colleagues would argue this point with me, but this is my opinion, is that when I see an individual patient, the exact diagnosis doesn't matter that much because we treat people very similarly, regardless of what kind of cognitive problem you have. And it doesn't matter whether you have this protein, the amyloid protein, or the synuclein protein causing Lewy bodies. It's all causing dysfunction of the brain, and we're just not good enough at targeting specific diseases for it to really matter 100%. So take that with a grain of salt, because your physician or others you might talk to may have different opinions, and that's fine. But that's just my opinion. So what's the incidence of diagnosis? So incidence is a term we mean for how many people develop a certain condition per year. So if you have Parkinson's disease, this was a study just from 2019, just this year. So within 3 years of diagnosis, they studied, I think there were 4,000 people in this study. So a big group of people with Parkinson's disease. And about a quarter of them converted to mild cognitive impairment within 3 years. So that's the one where you're not having trouble at home, but you just feel like you're not functioning properly, right? Now, 20% of these people with mild cognitive impairment went on to develop dementia in the first 3 years, but 28% reverted back to normal cognitive function. Yeah. So to me, this means there's a lot of pseudo-dementia, right? That there's a lot of people who have other issues going on. I mean, we know depression is common in Parkinson's. We know sleep problems are common in Parkinson's. It's Parkinson's patients are an older population. There's lots of medical issues, thyroid problems, anemia, right? There's lots of other things that could be going on. You get a hip surgery or something like that, and you're just a little, the anesthetic throws you for a loop for a few months, right? So this kind of sounds very bleak, right? But I think this is probably not as bad as it sounds, to be honest. And if you look at the overall numbers, really only 2% of these people within 3 years develop dementia, frank dementia. And my guess is a lot of these people didn't actually have Parkinson's disease. They have one of the more aggressive kind of Parkinson's plus syndromes, like Lewy body dementia, that can often be hard to distinguish from Parkinson's disease. Or MSA, or PSP. Yeah, exactly. So this is a bit more of a bleak study. So this was a study from Australia, and this is where they tracked down patients who'd had Parkinson's for 20 years. And so the caveat to this study is it's a small study. They only found something like 40 patients who they could find who had had Parkinson's for 20 years at that point. But about 83% of those people had dementia at 20 years. Now that said, so 17 of the people that they tracked down had autopsies, had postmortems. And 8 of them had diffuse Lewy bodies, which essentially means that the Parkinson's disease was the cause of their dementia. So those Lewy bodies that we saw in that picture, the pink picture back here, this is essentially what we see throughout the brain of a Parkinson's person. And so the diffuse Lewy bodies causes the dementia, whereas the others, so about half of them, had mixed pathology, meaning they've had Lewy bodies because obviously they have to have Lewy bodies because they have Parkinson's, but they have other things going on. They have vascular disease, they have Alzheimer's, they have something else. So it's, in my mind, I kind of read this and I say, well, half of these patients that they did postmortems on probably would have gotten dementia anyways, even without their Parkinson's. So yes, Parkinson's puts you at higher risk for getting dementia, but so does just being older, right?
So on this particular study, did they have age? How old were they?
Yeah, I don't remember that off the top of my head. My guess is they were probably 70s and 80s would be my guess. Yeah, but I don't know that exactly.
So in 20 years, you're going to start at 80 when you're 100. Well, what's the odds?
Exactly, right? So that's a great segue into this. So what are the risk factors for developing dementia if you have Parkinson's disease? Well, so as we talked about, these atypical Parkinsonisms, so PSP, MSA, dementia with Lewy bodies, and vascular Parkinsonism are all more likely to get dementia and get it sooner, right? These are technically not Parkinson's disease. These are other diseases that just kind of look like Parkinson's and can be misdiagnosed as Parkinson's, or Parkinson's can be misdiagnosed as these. Yeah. Yeah, PSP stands for progressive supranuclear palsy. Yeah, and MSA stands for multiple systems atrophy. So these are diseases where, again, you get protein that builds up in the brain and causes dysfunction of the brain. And we kind of lump them in with Parkinson's because you often look a bit like you have Parkinson's. You get the stiffness, the slowness, you get tremor sometimes, you get trouble walking. So they can look a lot like Parkinson's. We call these Parkinson's plus syndromes, but it's not Parkinson's disease. Parkinson's disease is a much more milder, more benign type of disease than these conditions, right? So if you have one of these, unfortunately, you're more likely to get dementia than if you have garden variety Parkinson's disease. If you develop hallucinations, you're more likely to develop dementia. Essentially, the worse your Parkinson's is, the more likely you are to develop dementia. The longer you've had the Parkinson's, the more likely you are to develop dementia. Males, probably for a lot of reasons, this probably has a lot to do with vascular factors, that males are just more likely to have strokes and heart attacks and have trouble with blood vessels and cholesterol. That, testosterone is just not kind to your brain, unfortunately. And then the older age, which kind of goes along with this. I think one of the keys here to look at this is you can't control any of these, right? So some of this is kind of inevitable, whether if you're going to get dementia or not. There's not a lot you can do. Now that said, there are some things you can do, right? So there are ways, we think of older age. I mean, how do you turn back the clock? Exercise, exactly. So how do you prevent dementia? Exercise. So I mean, this is kind of one of the big things, right? The more you exercise, the healthier your heart is, the healthier your lungs are, the healthier your blood vessels are, the less likely you are to get dementia. There's quite a bit of evidence that social and mental activity helps stave off dementia. So what does that mean? We don't really know. There's not, I know there are lots of groups out there and people who will try to sell you on different tests and programs and things. The evidence is pretty poor that any of those really prevent dementia. So we just don't know a specific program. People always come in and ask me, oh, should I be doing more crosswords? Should I do Sudoku? Should I play chess? And essentially I say you should do whatever makes you happy, right? Whatever you enjoy doing that keeps you socially and mentally active is what you should do. Because we just don't know exactly what exactly is going to help you. And then specifically managing your other medical issues. So, definitely if you have heart problems, if you have diabetes, if you have high blood pressure, all of those things put you at risk for getting dementia. So having good blood pressure control, good diabetes control, all of your other medical issues will help prevent dementia. Okay. So if you do develop dementia, what can we do about it? So other than the lifestyle stuff we just talked about, medications can be helpful. I will say right off the bat that these medications are not miracle drugs. We don't have a cure for dementia, and these medications are the benefits can be modest. We'll just say that. So there's a group of medications called the cholinesterase inhibitors, which essentially boost a chemical in the brain called acetylcholine. And they seem to help with memory and cognition. So a couple type names, just donepezil, this is the chemical structure down here, and rivastigmine is another one. And then there's another class of medications, or another single drug called memantine. It is an MDA receptor antagonist. Again, that seems to help with boosting memory a little bit. These, again, are not miracle drugs, but they can help a little bit to help boost your memory a little bit. And then if someone develops hallucinations, yeah. I'm not. No, it's a separate talk I have. So the long and the short of it is there's really no evidence that those help. Yeah. So she's just asking about supplements, vitamins, supplements, over-the-counter things. So I shouldn't say there's no evidence. There is some evidence that they can help. The problem with these drugs, these things, is that whenever they've done big studies with a lot of people, giving them like coenzyme Q or creatine or all these things, it doesn't really seem to help the majority of people. So there's no drug that you can really point to, or no herbal supplement or something like that you can point to that you can say like that will help your memory, and we have good hard evidence for it. So maybe that will happen someday in the future. There's still a lot of research into ginkgo and all these other kinds of neurocognitive substances, but we just don't have any evidence that they. Yeah, across the board. Yeah. There definitely is. Yep. Yeah. Yeah. I'm new to Canada, so I don't know exactly what the laws are in Canada, but I know in the US there's a lot of this kind of advertising, and the law essentially says as long as you don't say that it cures anything, you can advertise anything for anything. And I think that's a huge disservice to people. Yeah. So then if you develop hallucinations, there are a few different drugs that we can use to try to treat hallucinations in Parkinson's dementia. So quetiapine is pretty common. Clozapine is less common because it has a lot of monitoring. You got to get your blood checked regularly. Then there's kind of a newer drug, this pimavanserin, which is not available in Canada, but is available in the US. It's only been out for a year or so. So there are ways we can try to help if you're having hallucinations. And then lifestyle, a lot of lifestyle when you have dementia. Yes, exercise, everything we talked about is important, but a lot of management of dementia is really just keeping you happy, safe, healthy, enjoying life, right? So it's a lot of social interventions, right? And it's a lot of caregiver support. It's going to be very hard being a caregiver of someone who has cognitive problems. So advanced care planning documents. And I must say, this is something that coming to Canada, I think is much better, done much better here. I don't know what it is. You guys have great GPs or something like that here, because a lot of people have these where that my experience in the US was much different. So just before we go on to talking about advanced care documents, I just want to talk about driving. Because this comes up a lot, and that's, driving is dangerous, even for people who are healthy. And so, this is a study from 2017 showing that in the 3 years prior to a dementia diagnosis, so you're not even diagnosed with dementia yet, but you have a higher risk of getting in a car crash. Food for thought. So my advice to people about driving is always, it's better to give it up too soon than too late. Too late means something bad has happened, right? Okay. More happy stuff. You guys are doing great. There's kind of a bit of a debate in the Parkinson's community about, does Parkinson's shorten your lifespan? And there's studies out there. So this is what we call a forest plot, which essentially shows, one is the mortality rate of the general population here. And on the left, the study would show that you're less likely to die if you have the disease. So for this disease is Parkinson's. And on the right, it says you're more likely to die. So this is a lot of studies showing that you have a higher mortality. Just essentially you're more likely to die if you have Parkinson's. It's a difficult, well, I find it,
We're all going to die.
we're all going to die. That's right.
Exactly.
That's right.
They're not going to die any better than what we are.
That's true. Everyone's got to die of something, right? And the reality is, if you're diagnosed with Parkinson's and then you get, you fall off a cliff the next day because you're out hiking. I mean, did you die from the Parkinson's, or did you die? Were you going to die anyways? You have a heart attack 2 years later. I find this is a little hard to say for 100% that yes, your lifespan is going to be shortened. I think it's certainly harder to live with Parkinson's, and there's certainly risks involved with living with Parkinson's, right? I mean, falls are big risks, right? But whether you truly are going to have a shortened lifespan, I'm not 100% convinced. Yeah. I mean, I think that's a hard study to do because there's so few of them, right? I mean, not that they don't exist, but there's not big numbers of young onset Parkinson's people. So no, it's just less common. So it's, Parkinson's is a disease that is more common as you get older. And so there are just fewer numbers of people with Parkinson's in their 30s or 40s or 50s, and more in their 60s, 70s, and 80s. Yeah.
What do you call young diagnosis, and how many people go undiagnosed?
Oh.
For quite a number of years?
So I mean, we technically call this young onset Parkinson's, and that's anyone who's diagnosed before the age of 50 or so. How many people are undiagnosed? I don't know. I think that's a really hard question to answer. Yeah, definitely. Yeah. I think, it's probably getting better. I think doctors are more aware of Parkinson's. Probably 30, 40 years ago, it was not so, just wasn't out there, right? There wasn't a lot of awareness of the disease. No, no, no. But that goes for any condition. Being in a small town is hard. Yeah, it's a risk, definitely. Yeah.
Sorry, when you say studies, are you talking post-mortem, or if you've got the diagnosis,
Mm-hmm.
how would you be able to contribute an actual study baseline unless you're looking at post-mortem?
Yeah, so this is all just this would just be like death records. So this would just be you're also hoping that someone wrote on the death record Parkinson's disease.
Well, that's what I'm getting at.
Right,
So
yeah.
unless it's actually documented that this is a post-mortem due to Parkinson.
Right,
and
exactly.
then the next step after that is the brain stuff, right?
Yeah.
Unless we're studying that after
Yeah,
that.
which there's just you
Now I
can't
wanna
do
slow
that
down
many.
even more.
I agree. I mean, it's a complicated issue that's very difficult to study, right? And I think so. This was a study that I did. This is a picture of Portland with Mount Hood in the background. This is where I lived for 10 years. So this was a study we did of all the death records in Oregon, and it showed that the median age of death among people with Parkinson's was 83, which is along with, I mean, that's the median age of death for everyone, essentially. So there was no statistical difference between people with Parkinson's and people without, male and female. Yeah. So yeah, it's a difficult thing to study. So, and I think this is a key point here, right? Is that this author would say that people with Parkinsonism have reduced survival. However, it's highly dependent on the type and characteristics of the disorder, right? And a lot of it essentially has to do with cognitive function, right? So people who are healthy and they're with it and they exercise do really well. And this is a manageable chronic condition. And people who are not so healthy at baseline or who develop cognitive problems, those are the ones who are more likely to die. So we're going to take a deep breath. Okay, it's been some pretty heavy stuff, right? We're going to talk a little bit about, and hopefully you don't feel overwhelmed like this. But we'll talk a little bit about palliative care and stuff. So, my interest in palliative care kind of came about kind of in the middle of my residency training, and I was reading a book. This is kind of like these three authors, Dr. Fahn, Yankovic, and Hallett, are kind of like three of the gurus of Parkinson's disease in the U.S., and they wrote this book, and this is kind of their opening line about Parkinson's disease. And it said, essentially says, yeah, we can help you early in the disease, but later on, you're on your own. And this felt really depressing to me. And I thought this was probably pretty wrong, right? I mean, we don't say this about people with cancer. We don't say either we cure you or too bad. We don't say this about diabetes. We don't say this about any other chronic illness, right? That we can't help you once you're later on in the disease. And I think this really kind of triggered me to say, well, that can't be right. What should we or what could we do for people later on in the disease? And I think this is a great quote. And I just pulled this off the internet. I don't know who this person is or whether they really said it, but it's a great picture. Is she an actress? Oh. A singer. Oh. You don't think she said that? Okay. Maybe I'll try to erase that. I think this is really true, right? That it's the way you carry it, right? We all have problems in life, and we all have stresses, we all have struggles in life, and the way you carry that stress and that struggle, and who you have to help you carry the load, it really makes a huge difference on how much it impacts you. So, I think Parkinson's, a lot of the kind of paradigm of treating Parkinson's disease has been just patient and doctor, right? It's you come to your doctor, they prescribe you medications, and then you go home, and a year later you come back and see your doctor, and they adjust your medications, and you go home, and you struggle along, and there's not really any other kind of support, right? But I really think that Parkinson's, because it affects so many things, right? As we talked about, it's the hydra, right? The multi-headed hydra. You really need a lot of support. And maybe not early, right? Early in disease, maybe you're fine helping yourself, and that's great, right? The more self-sufficient you can be, that's great. But as things go along, you're going to need to pick up supports, right? And I think that involves you, your family, your caregivers, and numerous clinicians, whether that's doctors, physiotherapists, social workers, all those kinds of people. Because I can't do it all, and you can't do it all at some point, right? But again, I don't think this is specific to Parkinson's disease, right? This goes for everything. This goes for life, right? So what is palliative care? So this is the WHO definition of palliative care. So I think the key points are it improves quality of life. So we're not focusing on quantity. We're not trying to make you live longer. We're trying to make you have a better quality of life at the time. And it's not just you. We also treat your family, because your family is part of your system, part of your network, part of your unit. And we're talking about life-threatening illnesses. Now, for a long time, life-threatening illness, what did that mean? That meant cancer, right? But I think the paradigm is changing, where palliative care is focusing more on other life-threatening illnesses, right? So treatment of, pain, other problems, physical, psychosocial, spiritual. So it's not just movement symptoms, it's everything. It's all heads of the hydra, right? And, I really think they should put in here that it needs to be multidisciplinary, right? Because no one can do all this by themselves. So this is kind of this idealized version of how you would manage your Parkinson's disease, right? With the patient right in the middle here, your family kind of right next to you. You have a social worker, your neurologist, your speech therapist, your physical therapist, maybe an occupational therapist, kind of right in on the middle. And then if you need it, a gastroenterologist, if you need a psychologist, if you need a neurosurgeon, if you need a urologist, they can all kind of come in. So this idea that it's a team approach, right? A lot of different people supporting you and helping you. And this is kind of the way that palliative care tries to work, right? Palliative care really tries to see things as it's not just a doctor that's helping you, right? There's a whole team of people, support nurses, other doctors, occupational therapists, but also right in the middle, you and your family, right? I think that's hard, right? I mean, health economics is a really complicated subject. I think one of the issues with health economics is if you invest money up front, but then you save money down the road, where do you place that pro and con, right? Where do you take that money out and put that money back in? So this is a lot of the arguments that we try to make when we're talking to health systems about we want to do more. And the health system says, well, that costs money. And then we try to show them that you'll save money down the road if we do this up front. So you're right. I mean, you look at something like this and you're like, wow, it's a lot of people you got to pay to help out, right? That's going to be expensive. But if this keeps you out of the hospital, if this keeps someone working, if this keeps someone paying taxes because they're still working, if this prevents you from having to do a hip replacement because they fell and broke their hip, that's all saved money, right? So I'm not a health economist, and I don't know all the numbers behind this, but there is a group in Edmonton led by a Dr. Miyasaki, Janice Miyasaki, who is running a palliative care clinic for people with Parkinson's. And she's trying to do a lot of this kind of number crunching and see, what is the value of palliative care? Is it saving money, essentially? We had a palliative care clinic when I was in Oregon where you would come in and you would see in one appointment, you'd see myself, you would see a physiotherapist, a speech therapist, and a nurse and a social worker all in one appointment. And we kind of calculated that even just one trip to the doctor saved you more money than we spent on this. Just that people didn't have to keep coming and going. Especially people, if you had to come from far away, you're driving, 2 hours to come to the doctor. If you had to do that 3 times to see 3 different people, just the money you save in time and gas mileage, it's worth it to have that kind of a system. So I think you can make those kinds of arguments for health economics, that this is worth it. But do we have exact numbers yet? I don't think so. Yep. Yeah. So it's a great question. I'm glad you asked that. So hospice care is really, I think, is part of this, is part of palliative care. So hospice care is essentially when you've decided you're no longer going to be pursuing curative treatment, and you're really just aiming to keep the patient comfortable. And hospice there's kind of two ways of doing hospice. There's home hospice and there's inpatient hospice. So home hospice is essentially there's a group of nurses who will come to your home and they will set you up with a hospital bed, and if you need medications, they make sure you've got your medications. If something goes pear-shaped at 3 a.m, you can call and there's a nurse who will come in and help you out. And then there's inpatient hospice, where essentially you're in a facility, and it's essentially like being in the hospital. But the goal in that facility is not to cure you. The idea is not to eventually get you home. The idea is to help you have a comfortable death. So hospice is really just kind of part of palliative care, is the way I see it. More focusing on kind of the end of life, right? When things have gotten to a point where kind of death is inevitable. Right? Not that it isn't, it's always inevitable, I guess. But yeah. Yeah. We don't, no. So the clinic I have in Victoria is me. So, but I think that is the goal. I think they hired me in order to eventually try to build something like this. So I must thank Parkinson's BC, because they are going to actually fund us to have a speech therapist in the clinic. So they've generously donated money for us to have that, because I think that's a huge need in Victoria. And so they're going to fund it for a few years, and then the health authority is going to take over, and hopefully piece by piece we will grow. Okay, we're running short on time. I'm just going to kind of go through quickly. These are just some basic goals of palliative care. This is all the stuff that we've talked about, essentially. We're making you happier, reduce hospital admissions, reduce fragmentation, make things more efficient. So services vary a lot by region. We kind of briefly talked about the clinic in Edmonton. I don't know of any other specific PD palliative care clinic in Canada. There are a few in the US, but that's the only one I know of in Canada. But there are certainly palliative care doctors everywhere. And they used to focus a lot on cancer, but I think they are expanding their purview. And I think the doctors in at least in Victoria, I've talked to them, and they're more interested in seeing more neurology patients. So you just have to, if you think it's something you're interested in, even you just want to go chat with a palliative care doctor, just be the squeaky wheel, get a referral, and see what they can do for you. So then just briefly, advanced care documents, I think this is a really important thing, but you guys seem to do this really well in BC. I don't know why. But making sure, the reality is everyone should have these. This shouldn't just be something that Parkinson's patients or people with illnesses think about. We should all be thinking about planning for the future, with wills and advanced directives, healthcare powers of attorney, and the the most, which is this, I assume you guys have the same thing here, this kind of where you fill out a form ahead of time, so if the ambulance ever shows up at your house, they know exactly what you would want. Do you want CPR? Do you want intubation? You know, what your health wishes are in an acute event. Yeah. So usually a social worker would help you do this. So I think Parkinson's BC could help you do this. I know in Victoria we have a local support group with a social worker who will walk people through all of these different forms and things. So you'd probably start either with Parkinson's BC or talk to your GP about getting a referral to a social worker.
Also, My Voice is BC, and if you go to your health authority, they should have all the information, and if you want someone to come out and speak to your group, they're more than willing. It's called My Voice.
My Voice, okay, great. All right, again, do your will too early, not too late, right? So I think I just like ending with this quote because this is a great quote. So this is a guy, Atul Gawande. You may have heard of him. He's a surgeon in Boston. It's a great book. I really recommend reading this book, Being Mortal. Amazing. And he's got just this great quote that, you know, and this book kind of talks about his journey from being your kind of typical surgeon who really just didn't care about people and just wanted to operate to really caring about the patient and realizing the patient's more important than the gallbladder, right? And so, you know, this kind of thought that it's, you know, our job is really to enable well-being and, you know, find you a reason for being alive. Yeah. Yeah, being immortal. So I think that's it. We've had a bit of question and answer, but we've got some time for Q&A if you guys want to talk about anything else.
All right. We got 5 minutes for questions.
Oh, I've got a loud enough. All right. And I think I know the answer, but let's just say someone Parkinson has died. Is
No.
there really, like, Parkinson's, you do not die of Parkinson's, but you perhaps die from complications arising from? I don't know. That is my question.
Yeah.
Actually die of Parkinson's.
Do you die of Parkinson's? So, do you die from a heart attack? Do you die because your heart stops beating? Or do you die because you're not getting enough blood to your brain? Yes. Exactly. Exactly, right? Do you die of pneumonia? Do you die because there's an infection in your lung, or you die because you're not getting enough blood to your brain because you're not breathing well enough? So it's kind of it's a strange question in my mind. What do you die from, right? So certainly people with Parkinson, you die from complications of Parkinson's. I guess you fall, you hit your head, you fell because you had Parkinson's. You know, you get pneumonia, maybe because you're too stiff and slow and you're not clearing your secretions, you're having trouble with your swallowing. That's all from Parkinson's. Did the abnormal proteins in your brain actually stop your brain from working 100%? No. I mean, we all essentially die because we're not getting enough oxygen to our brain. That's how everyone dies, essentially. And I think in medicine, you know, when I was in medical school, when we'd write out death certificates, we'd all just write cardiopulmonary arrest. Everyone died of cardiopulmonary arrest, right? Because that's the reality. Your heart stops, and then you're not getting blood to your brain, and you die. And I think, you know, the statistics people said, well, we probably should be making this a little more specific. And so now we write, you know, different reasons, you know, complications or other diseases you had. So, yeah, right. Yeah, so it's a good question. You know, everyone's different, but yeah, I mean, if you can think about the slowness, the stiffness gets worse and worse and worse over time. Tremor often burns itself out at some point. So a lot of people with tremor near the end, they don't tremor because the stiffness and slowness takes over, right? And you have a lot of trouble moving. So the two big things that kill people with Parkinson's are falls and pneumonia. And that's from just trouble swallowing. You get, even just saliva down the wrong pipe. You get an infection. You're not able to move around, and your immune system can't fight it, and you die. Oh, does it? Yeah. I don't know if we have evidence whether chronic low blood pressure causes cognitive problems, but we certainly know in the moment that your blood pressure is low, your brain doesn't function well. So they've done plenty of studies where you lie people down, you give them a test, they do pretty well. Stand them up, blood pressure drops, give them the same test, and they don't do as well. So yes, it's a big thing. And that's probably, when we talked about pseudo-dementia, that might be one of the contributors to that as well, is your just blood pressure is too low. I've seen quite a few people like that. Yep. Yep.